Good morning, good evening all. Today I'm here to present myself Dr. Shivi Trivedi, as a professor in this Department of Physiotherapy and Biomedical Sciences. Today, we are here to present our topic, that is ankle biomechanics. First of all, we are discussing about the osteokinematic of the joint. In this, only one degree of freedom is present. The axis of rotation passes from the tip of both the melodi. Since the lateral melodi lies more inferiorly and posteriorly, the axis of rotation is deviated superiorly and anteriorly. The axis is deviated for about 10 degree from true mediolateral axis. About 26 degree of dorsiflexion and 48 degree of frontal flexion is evident at the joint. Associated movements contribute to about 20% of the movement. Neutral position of ankle is defined as when the foot is perpendicular to the leg. In arthrokinematic, we are discussing that during dorsiflexion, the superior surface of talus rolls forward and related to the leg and slides posteriorly. The posterior slide allows the talus to rotate forward without much anterior translation. Calcaneofibular ligaments get taut in response to posterior sliding tendency of talocalcaneal ligament. During plantar flexion, superior surface of talus rolls backward and slide in anteriorly. Initially, it stretches TFL, followed by full stretch of tibionavicular fibers of dental ligament in full frontal flexion. Progressive stabilization, progressive stabilization of telecrular joint toward the stance face of gait. Thus, after the heel contact, ankle plantar flex to lower the foot to the ground. At foot flight, the leg start to dorsiflex over the fixed ankle and continue till the heel of face. At this point, the ankle becomes stable in the gait cycle, owing to greater tension in many stretch, collateral ligaments, and plantar flexor muscles. At complete dorsiflexion, the talar head fits into the mortise, causing the distal tibiofibular joint to set wide apart, leading to stretching of distal tibiofibular ligament and interosseous membrane. The joints get well stabilized and prepared to accept compression forces that may reach over 4 times body weight. This is the ligaments involved. This is tibia dental ligament. Primary joints involved are talocrular joint, movements that stretch or elongate ligaments, eversion dorsiflexion with associated posterior side of talus within the mortise. Second one is lateral ligament. Primary joints involved are talocrular joint, and this eversion plantar flexion with associated anterior slide of talus within the mortise. In talonavicular joint, eversion and adduction movements are stretch. In dental ligament, talocrural joint and subtalar joint, eversion is involved. Anterior tibia of talofibular ligament. Talocrural ligament. Talocrural ligament. Anterior tibiofibular ligament. Anterior tibiofibular ligament. Talocrural joint. This plantar flexion will associate anterior side of the within the mortise inversion adduction. Calcaneofibular joint. It is talocrural joint. Dorsiflexion was associated posterior slide of the talus within the mortise inversion. Subtalar joint inversion. Posterior talofibular joint, talocrural joint. Dorsiflexion was associated posterior slide of the talus within the mortise abductor inversion. In subtalar joint, the concave posterior facet of talus rests on the convex posterior facet of calcaneus. The joint is stabilized by its congruent articular surface, interosseous ligament, etc. The anterior and middle, the anterior middle articulation, the anterior middle articulation are mostly flat. Ligaments involved are posteriorly stability is provided by medial posterior lateral calcaneal ligament, but these are secondary stabilizing structure apart from the lateral ligament, larger ligament. Other ligaments include interosseous ligament and cervical ligament. As a connective tissue, both these ligaments make a Strong bond between talus and calcaneus. Ligaments limiting eversion includes medial fibers of interosseous ligament and tibiocalcaneal fiber or deltoid ligament. Ligaments limiting inversion including cervical ligament, calcaneofibular ligament. Articular surfaces of subtalar joint. Articular surface of cuboid at anterior facet, middle facet, and posterior facet. Kinematic of subtalar joint. It involves sliding of three sets of facets yielding calcaneal arc of movements between the calcaneus and talus. The axis of rotation is typically positioned 42 degrees from the horizontal plane and 16 degrees from sagittal plane. This is the structure. The calcaneus pronates and supinates in a path perpendicular to the axis of rotation. Only two components of pronation and supination are evident at the subtalar joint, that is component supination and components of pronation. Range of motion of subtalar joints on an average inversion extend to the double of eversion. Upon 22.6 degree of inversion and 12.5 degree of eversion is present at the subtalar joint. Transverse tarsal joint. The transverse tarsal joint and mid-tarsal joint or copard joint. The transverse tarsal joint consists of two articulations, that is talonavicular and calcaneocuboid joint. The transverse tarsal joint is stabilized by a medial longitudinal arch. Talonavicular joint. Joint is made by convex head of talus and proximal concavity of navicular and dorsal surface of plantar calcaneal ligament, spring ligament. The spring ligament is thick and wide, spanning the gap between the substanticulum talus of the calcaneus and plantar surface of navicular. The spring ligament supports the head of talus when the body weight depresses it. Posteriorly, the capsule is thickened by the interosseous ligament of the subtalar joint. The capsule is extended dorsally by talonavicular ligament and laterally by calcaneonavicular fibers of bifurcated ligament. Medially, the capsule of the talonavicular joint blends with the anterior edge of the deltoid ligament. The ball and socket-like articulation of the joint provides significant rotation to the medial side of the midfoot. In calcaneal cuboid joint, it is formed by the articulation of anterior aspect of calcaneum and proximal surface of cuboid. Each articular surface has both concave and convex curvature forming an interlocking wedge that resists sliding. Joint is relatively inflexible, providing rigidity to the lateral column of the foot. Dorsal surface of the capsule is thickened by dorsal calcaneocuboid ligament. The joint is also stabilized by bifurcated ligament. It is a Y-shaped band with the stem attached to the calcaneus. The stem flares within the medial and longitudinal fibers, where the medial fibers reinforces the dorso-lateral side of the talonavicular joint, and lateral fibers cross dorsally forming the primary bone between the bones. Long plantar ligaments, it is the longest ligament in the joint arising from the plantar surface of calcaneum anterior to the calcaneum tuberosity and inserting on the basis of lateral metatarsal bones. Short plantar ligaments arises anterior and deep to calcaneum tuberosity and inserting on the basis of lateral metatarsal bones. Short plantar ligaments are arises anterior and deep to long ligaments and inserts on plantar surface of the cuboid bone. In plantar view, we have seen that for in the right side, first metatarsal joint, tibialis anterior, tibialis posterior, navicular tuberosity, plantar calcaneal navicular, flexor digitorum longus, flexor hallucis longus. On the left side, peroneus brevis, peroneus longus, plantar calcaneal cuboid joint, long plantar ligament. Kinematic of ankle joint, transverse tarsal joint rarely moves alone but in conjunction with the or other adjacent joints. During supination and pronation, navicular spins within the talonavicular joint. The combination of rotation at both subtalar and transverse joint account for most of pronation and supination. Osteokinematics are movement at the transverse joint is done around two separate axes. The two axes are longitudinal and oblique, and motion at transverse joint occurs in a plane perpendicular to this axis. Longitudinal axis is similar to the straight anterior-posterior axis. Oblique axis follows more of medial-lateral axis. Motion about this axis occurs in combination of abduction plus dorsiflexion and adduction plus plantar flexion. Range of motion is difficult to measure, but supination is twice of pronation. Arthrokinematic of the joint is the tibialis posterior muscle is the prime supinator of the foot because of the relative rigidness of calcaneal cuboid joint. The lateral column comes under the medial column of forefoot. The pivot point for this becomes the talonavicular joint. The pull of tibialis posterior rotate and spin the navicular and raises the medial arch of the foot. During this rotation, the concave proximal surface of the navicular and spring ligament spin around the convex head of talus. During supination and pronation, the pull of peroneus longus, especially in pronation, the pull of peroneus longus contributes to the lowering of medial side and a raising of the lateral side of the forefoot. Medial longitudinal arch of foot. The medial concavity of the foot is made by the medial longitudinal arch. The keystone of this arch is located near the talonavicular joint. Arch is basically the load-bearing and shock-absorbing structure of the foot. Contributing bones include calcaneus, talus, navicular, cuneiform, and three medial metatarsal. The height and shape of medial arch is maintained by plantar fascia, spring ligament, stability of medial metatarsal joint, short plantar ligament, intrinsic extensive muscles of the foot. Plantar fascia, it is a primary support of the medial longitudinal arch. The fascia consists of extensive series of thick, very strong, longitudinal and transverse band of collagen-rich tissue. It is organized into superficial and deep layers. The superficial fibers attach to the thick surface and then function to the reduced shear force and provide shock absorption. The deeper fiber attaches to the medial calcaneal tuberosity. From this origin, central, medial, and lateral fibers course anteriorly, covering the first layer of the intrinsic muscle of foot. Anteriorly, they attaches to the plantar ligaments. Support of the medial arch. This is active muscle force and passive forces produced by combined elasticity and tensile strength of connective tissues and shape of the bone. Now, passive forces supporting medial arch. The pressure under the forefoot is usually greatest in the region of second and third metatarsal head. Body weight tends to depress the talus inferiorly and flatten the medial arch. The action increases the distance between metatarsal and calcaneum. While the arch is depressed, the rear foot tends to pronate, whereas while in the unloaded position, the calcaneum inverts and returns back to its position. Studies have shown significant EMG activity in tibialis posterior muscle and intrinsic muscle of foot in loaded condition. Distribution of compression forces across the foot while standing, that is rear foot heel 60%, forefoot 28%, midfoot 8%. Arch height is measured directly by determining the height of the navicular or the dorsum of the foot from the ground during weight bearing. The arch index provides an indirect measure of the integrity of the arch by examining the amount of contact with the ground made by the midfoot. Subtalar neutral, defined as the position of the subtalar joint that is neither pronated nor supinated. Subtalar neutral position appears to maximize the area of contact between the talus and the calcaneums, and movements away from the subtalar neutral position into pronation or supination decreases the contact area. The angle made by a line bisecting the leg and another bisecting the posterior aspect of the calcaneus quantifies the subtalar position. This is pes planus foot and this is pes scavus foot. And this extensor muscle works on downwards and it compresses the intrinsic muscles. And this is pes clavus, which is high arch foot. Combined action of subtalar and transverse joint, that is joint interaction during stance phase. During most of the stance phase, the arch lowers slightly in response to the progressive loading of the body weight. A structure that resists the lowering of the arch helps to absorb the stress of the body weight and protect the foot. During the first 30 to 35% of gait cycle, the subtalar joint everts pronates to add flexibility to the midfoot. By lateral stance, arch arises as the supinated subtalar joint renders the midfoot relatively rigid. This makes the foot able to be a large bending force during push-off phase. Early stance phase pronation has a subtalar joint. Kinematic mechanism of pronation is immediately following the heel contact facts, the dorsiflex ankle joint and supinated subtalar joint rapidly plantarflex and pronate. The excessive pronation at the subtalar joint is carried out by two mechanisms. The ground reaction force, first is the ground reaction force passes lateral to the anterior posterior axis through the calcaneum, leading to eversion and adduction at the subtalar joint. At the heel strike, the lower leg along with the femur is in internal rotation, which leads to pronation of foot and vice versa, since the calcaneum is already in contact with the ground. Amplitude of the pronation is about 2 to 3 degrees and lasts for about 1 to 4 of a second. While standing in loaded foot condition, the lower leg entirely rotates and the subtalar joint pronate and simultaneously the medial arch lowers down. In a forceful condition, the hip also internally rotate, slightly flex, adduct causing valgus strain on the knee. Because of the linkages in the lower limb, excessive pronation may lead to medial knee pain, apparent genu-valgus strain, and overstretching of medial long collateral ligament. Now, kinesiological benefits of controlling normal pronation. Pronation at the subtalar joint permit interrotation of the talus and the entire lower extremity against a firmly planted calcaneus. Without such a joint mechanism, the plantar surface of calcaneus would otherwise spin. Eccentric activation of supinator muscles such as tibialis posterior can help to decelerate the pronation and resist the lowering of the uh, medial longitudinal arch. Controlled pronation of the subtalar joint favors relatively flexibility throughout the midfoot, allowing the foot to accommodate to the varied shapes and contours of walking surfaces. Consequences of excessive pronation, that is first, laxity or weakness in the mechanism that normally support and control the medial longitudinal arch. Second, abnormal shape or mobility of tarsal bones. Third, excessive femoral anteversion. Fourth, generalized muscle weakness or reduced flexibility. In each case, a structural fault causes a rare foot to fall into excessive eversion following heel contact. Often, excessive subtalar joint pronation is a compensation for either excessive or restriction movement throughout the lower extremity or restricted movement throughout the lower extremity, particularly in the frontal and horizontal planes. The most common conditions, the structural deformity is rare foot varus. As a response to the deformity, the subtalar joint overcompensate by excessively pronating in speed or magnitude to ensure that the medial aspect of the foot contact the ground during stance phase. Similar compensation occur as a result of hind foot varus. The associated excessive internal rotation talus and leg may in some cases create a chain reaction of kinematic disturbances and compensation throughout the entire leg. The abnormal kinematic sequence between the tibia and femur may cause an increased Q angle at the knee and the increased net lateral pull of the quadriceps or iliotibial bend on the patella. The situation may predispose the patient to patellofemoral joint dysfunction. Furthermore, extensive factors such as footwear, orthotics, terrain, and speed of walking or running alter the kinematic relationship within the foot and lower extremity. Mid to lateral stance phase, supination at the subtalar joint. Kinematic mechanism related to supination. At about 15 to 20% into the gait cycle, the entire stance limb dramatically reverses its horizontal plane motion from internal to external rotation. External rotation of the leg while the foot remains planted coincide roughly with the beginning of swing phase of the contralateral lower extremity, with the stance foot secure planted external rotation of the femur, followed by the tibia, gradually reverses the direction of the talus from internal to external rotation. At about 35% of gait cycle, the pronated subtalar joints start to move towards supination. With the rear foot supinating in the midfoot and head foot must simultaneously twist into relative pronation in order for the foot to remain in full contact with the ground. By lateral stance, the fully supinated subtalar joint and elevated and tensed medial longitudinal arch convert the midfoot into more rigid lever. Muscles such as gastrocnemius and soleus use this stability to transfer forces from the Achilles tendon throughout the midfoot to the metatarsal head during the push-off phase of walking or running. Distal metatarsal joint. The primary function of this joint is to provide stability across the midfoot by formation of transverse arch. Cuneo-navicular joint. It is formed between the anterior side of the navicular and posterior surface of the three cuneiform bones. Plantar and dorsal ligament around the joint. These slightly concave surface of each cuneiform fit into one of three slightly convex face sets on the anterior side of navicular point, the large medial facet of the navicular except the large medial cuneiform. The major function of this joint is to help transfer pronation and supination movement distally through the medial midfoot to the forefoot. Now, cubital navicular joint. It is a small fibrous joint located between the lateral side of the navicular and proximal 1/5 of the medial side of the cuboid. It can assist in transferring pronation and supination movement across the more proximal region of the midfoot. It is extended by dorsoplantar and tertius ligament. This is the structure on the right side. Achilles tendon is present. Subtalar joint is present. Transverse navicular joint is present. Cuneo-navicular joint is present. Intercuneiform cuneo-cuboid joint complex is present. Transformator structure is present. On the left side, calcaneal-cuboid joint and calcaneal-navicular joint is present. In A structure, this structure is for distal phalanges. Distal phalanges are present. IB joint are present. Metatarsophalangeal joints are present. On the right side, on the left side, intermetatarsal joint, transverse metatarsal joint, intercuneiform, cuneo-navicular, cuboidal-navicular joint, pteronavicular joint are present. There are three parts of the foot: forefoot, midfoot, and rear foot. Now enter cuneiform and cuneo-cuboid joint complex. It is formed two between cuneiforms and one between the lateral cuneiform and medial surface of cuboid. Articular surface of the essentially flat and aligned nearly parallel with the long axis of metatarsals, surrounded by dorsoplantar and tertius ligaments. The intercuneiform and cuneo-cuboid joint complex form transverse arch of the foot. Under the load of body weight, the transverse arch depresses slightly, allowing the body weight to the shared across all five metatarsal head. Now, tarsal-metatarsal joint. This is anatomical consideration. Joint is formed by articulation of base of metatarsals and distal surface of the three cuneiform and cuboid joint. First metatarsal articulate with the medial cuneiform, two with the intermediate uniform, and third with the lateral cuneiform. The base of fourth and fifth metatarsal articulate with the distal surface of cuboid. The articular surfaces are essentially flat and stabilized by dorsal plantar anterosseous ligament. Kinematic consideration: mobility is least at the second tarsal joint due to the waist position of its base between medial and lateral cuneiform. Secondary forms a stable central pillar to the foot, similar to the third ray in the hand. This stability is useful in that instance as the forefoot prepare for the dynamic of push-off. Mobility is more in peripheral transmetatarsal joint with dorsiflexion and plantar flexion combined with inversion and eversion. At the first state, dorsiflexion occurs naturally with inversion and plantar flexion with eversion. The first transmetatarsal joint provides an element of flexibility to medial longitudinal arch. During the loading phase of walking, the first state dorsiflexes slightly under the force of body weight. The stiffness of the first ray limits the shock absorption ability of the medial longitudinal arch. Intermetatarsal joint function. Base of full lateral metatarsal are interconnected by plantar dorsal anterosseous ligament. A true joint does not typically form between the base of first and second metatarsal. This lack of articulation increases the relative movement of the first ray. All five metatarsals are interconnected by deep metatarsal ligament. Metatarsophalangeal joints. Joints are formed between convex head of each metatarsal and shallow concavity of the proximal phalanx. These joints can be uh, palpated above 2.5 cm proximal to the web of toes. Articular cartilage covers the distal end of each metatarsal head. A pair of collateral ligament is present on each side, blending and reinforcing with capsule. Each collateral ligament courses obliquely from a dorsal proximal to plantar distal direction, forming a thick cord and fan-like necessary portion. Necessary portion attaches to the thick dense plantar plate. The plate or ligament is grooved for the passage of flexor tendons. Fibers from the deep plantar fascia connect into the plantar plates and sheaths of flexor tendon. For deep transfer metatarsal ligament, blend with and join the recent plantar plates of all five metatarsal phalangeal joint. They had to maintain the first ray in a similar plane as the lesser ray, thereby adapting the route for propulsion and weight bearing rather than manipulation. A fibrous capsule encloses each joint and blend with collateral ligament and plantar plates. A poorly defined extensor mechanism covers the dorsal side of each joint. Kinematic consideration: the joint has two degrees of freedom: extension or dorsiflexion and flexion or plantarflexion in the sagittal plane around medial lateral axis, and abduction and reduction occur in horizontal plane above vertical axis. Passively, it can be hyperextended to about 65 degree and flexed to about 30 to 40 degree. The first two typically allows greater hyperextension to nearly 85 degree. Now, anterior compartment of muscle. Dorsiflexor are the pre-tibial muscle, including tibialis anterior, extensor hallucis longus, extensor uterum longus, and peroneus tertius. Tibialis anterior also inverts the subtalar joint by passing medial to the axis of rotation. It inverts and adduct the talonavicular joint and support the medial longitudinal arch. The primary action of external hallucis longus is to dorsiflex the taloclear joint, an extension of first toe. These muscles are active during early stance phase and again throughout the swing phase of gait. During early stance, the muscles are essentially active to control the rate of plantar flexion. To control the rate of plantar flexion. Similarly, tibial anterior decelerate the lowering of medial longitudinal arch and pronation of the foot. The action of peroneus and extensor digitorum longus muscle of eversion and abduction counteract the inversion and abduction action of tibialis anterior. Now, lateral compartment of muscles. Peroneus longus and brevis are the primary everters of the foot and also plantar flexor of the talocrural joint. Lateral malleolus serves as fixed pulley and pulls the peroneus tendon posterior to the axis of the rotation. These muscles abduct the subtalar and transfer tarsal joint. The distal attachment of peroneus longus provides an ideal line of force for pronation of forefoot. Peroneus longus also stabilizes the TMT joint against the medial pull of tibialis anterior, without which the first tray would migrate more medially and predisposing to hallux valgus deformity. The peroneus longus and brevis are most active throughout the mid to late distance phase when the subtalar joint is supinating or dorsiflex, ankle joint is preparing to plantar flex. At the push-off phase, the peroneal muscle work to assist and plantar flexors. As the heel is raised, contraction of peroneus longus muscle helps to transfer the body weight from lateral to medially so that the center of gravity of body shift towards the opposite limb, which is getting into the weight bearing. Now, posterior compartment muscles which is present. Superficial groups are gastrocnemius, soleus, plantaris. Deeper group muscles are tibialis posterior, flexor digitorum longus, trajector hallucis longus. Posterior tibial muscle, its tendons lie superficial to flexor digitorum longus. Its tendon passes deep to flexor retinaculum and superficial to deltoid ligament. At this point, the tendon divides into superficial and deep parts, stabilization attachment to every tarsal bone except talus. Its function serves to stabilize the median longitudinal arch. Kinetic interactions are from flat foot to just prior to heel off. The plantar flexors act eccentrically to decelerate dorsiflexion over fixed talus. Between heel off and toe off, the muscle switches to a concentric contraction to provide a thrust for push off. The maximal plantar flexion torque is at complete dorsiflexion. Gastrocnemius is a biarticular muscle, so it is affected by the position of knee, whereas soleus is a slow twitch muscle and subjected to control the relatively slow slunging foot movements in standing. The protruding calcaneal tuberosity provides a long movement arm of 4.5 cm to the triceps surae at the talocrural joint, which therefore produces about 80% of total torque. Now, function of tibialis posterior, flexor hallucis longus, flexor digitorum longus. These muscles assist with the plantar flexion at ankle in late distance phase of walking. During mid and late distance, flexor hallucis longus, flexor digitorum longus, lumbricus, and interosseous pulls the plantar surface of the foot against the ground, therefore expanding the surface area of weight bearing. Tibialis posterior is the most active muscle of the foot during stance phase, especially from before foot flat to heel off. During weight bearing phase, the tibialis posterior contracts eccentrically to decelerate the lowering of medial longitudinal arch, thus absorb some of the impact of loading. Throughout the mid to late distance, tibialis posterior, flexor hallucis longus, flexor digitorum longus, has to guide the forefoot into supination as lower leg externally rotate, thus supporting medial longitudinal arch. Thank you. This is all about the biomechanics of ankle joint, which is sufficient for bachelor students actually.